we've had the privilege of joining Scott and White, evolving towards a relationship with Scott and White over the last 3 years, but it really kicked off in January when they formally took over our Llano healthcare system with our 5 rural health clinics in the area. And I thought it'd be nice to just tag team what Dr. Watson talked about with Temple and what you're probably going to hear from Seton regarding the Austin markets. The bigger urban communities obviously deal with indigent care and healthcare in general different than we do in the rural areas. I'm going to kind of compress this. I think I've got a time squeeze, but some of what we do financially to fund our healthcare is almost inversely related to how Dr. Watson described the model in an urban setting and urban hospitals, with commercial payers being the more predominant funders of healthcare. So we're going to talk a little bit about that, and let's see, push down. Okay. This slide is just a little humor, just to give those that are uninsured maybe a little. They don't have to deal with some of the problems insureds have with getting payment for some of their coverage. This is just an indication that insurers are tougher and tougher on paying for things, and that's their method of controlling costs, and I think it's probably in the right direction where we all need to be going. This is a map of all our rural health clinics in the United States. You see where there's a bunch of them, 3,200. No, I'm sorry, that's not the right number. I'm not sure it's even on here. Texas has well over 400, and that's what we're going to kind of talk about. This next map is about the federal qualified health centers that we also have in our area. The nearest one is in Mason, and Dr. Watson mentioned the one in Round Rock. Lone Star Care Centers has several in the Williamson County area. We're going to talk more about the rural health clinics because that's what we present here in our area. These are some quick demographics, and just want to let you know, just the column on the right shows you that Texas has 8.1% of the total population. We also have 8.4% number of hospitals, almost the same in rural hospitals. A little less than the critical access side, but that's a growing number. RHCs, we've kept up RHCs equal to the population. So that's what we're going to talk about. Again, I'm going through this a little quicker. We won't talk about everything. These are some fundamental issues that rural health clinics require. If you want to get the HPSA facility designation, which we actually do not have in our 5 rural health clinics, and I don't know that Seton has got that for their 3 in the area either. It came about as an option in 2002 to basically enable you to work more as a community health center and have some capital dollars, $500,000 grant each year. So I bring it up mainly because that's an opportunity that we can potentially advance to bring more funding into our existing setups. But the key is you can't deny services to anybody. You have to have a sliding fee schedule for those that have the underfunded poverty class. You do have to make reasonable efforts to collect any discounted portion from those patients, and copays are very much encouraged, even if it's $5 or $10 per visit. Obviously, you have to accept Medicare assignments, Medicaid assignments, and including the managed Medicaid plans, which the state is thinking can save money if we push the Medicaid products out to commercial carriers. Obviously, you have to make efforts to collect any bill of services. I'm going to ask you to real quickly, I want to kind of explain our model and the advantages, which I inferred earlier. We really can get more money from our payer sources through Medicare and Medicaid programs because of our provider-based rural health clinics. And real quick, I want to go through this. This is a typical clinic. We have 5 clinics, and if you divided them in 5, we would have 5 providers. They are different sizes, but this is kind of an average scenario of one of our clinics that generates $4.2 million of revenue in the course of a year, and 43% of that is Medicare revenue, 19% is Medicaid, 28% commercial, and 10%, here's the uninsured that we are obligated to see, open our doors to. But these percentages are the key to driving how we're paid. Again, if you look at that same clinic, over the course of the year, we developed about $2.35 million in expenses, salaries, physicians, contracted services. We do have the advantage, being provider base, of having some support costs funneled out to those clinics, billing support that we do at the hospital, IT support, environmental services support, that kind of thing. So we push costs out to this total out to those clinics. Back to that 43% Medicare, 19% Medicaid, we're entitled to be reimbursed that 62% of this $2.3 million. So that's where these dollars are here. And those are reimbursed through the number of patients that we see on a yearly basis. So we had, in a typical time, we'd see 7,300 Medicare visits and 2,800 Medicaid visits. Dividing that back into those costs here, again, I know this may sound elementary, but that's what we get, where we get this encounter rate, which is also called the all-inclusive reimbursement rate. That's what CMS calls it. But that's how much we get paid for a visit from a Medicare patient that comes through our doors. Real quick, we'll talk about the pros of that. Obviously, the biggest advantage of that model is that the cost of bringing in a physician or recruiting a physician and paying him a fair salary is all built into that cost recovery program. So I keep hitting the wrong button, sorry. So we have minimal risk in recruiting as our demand grows. And it's also easy to determine what the copay is for the Medicare patients. This doesn't apply to Medicaid, but Medicare has to pay 20% of the encounter rate. It's an easy calculation. We keep providers' attention on patient care and not on their ability to pay. You know, they're seeing whoever walks in the door without even thinking of it. It promotes more of a clinic focus on your population you serve, because it's back to this, you're not worried about their payment, ability to pay, or any of their issues. You're focused on taking care of your entire population. It's not as volume driven as it needs. I mean, that's the reason rural health clinics were created in the first place. Is it was so hard to get doctors out to these rural areas where the volumes were low, and you couldn't make a living if billing on the volumes that you'd see on a daily and weekly basis. So again, we can exist without the higher volumes that are seen in the urban areas. Again, it encourages creating ease of access for patients, because you can always have that extra staff if your demand requires it. This last one, I just want to bring up the SGR spending limitation, which is we'll be hearing about it again as it gets closer to the first of the year. Congress has kept pushing back the cuts that have been talked about for physician payments that were scheduled several years ago, and they kept putting it off. So every year it grows by 2 or 3%, and now we're up to this huge 30% potential cut to physicians. That's a pill that's the society has to swallow one of these days, and I don't know exactly the fix. It may get pushed off again, but those are huge dollars that have to be recovered somehow through the Medicare program. And our doctors through this model are pretty much immune to that, so that's a real advantage for us with the rural health clinic. Some disadvantages are there's more patient intervention needed. When patient intervention is needed for specialty care, there's not the avenues built into the rural health clinic model. Obviously, sometimes we can't take care of things in our clinics, in our primary care facilities, hospital. And sometimes it is a challenge to get specialty care pushed up. That's one advantage we have here in the hill country, though. with our rural health clinics having a seat in Austin as a parent company, and now we have Scott and White. So we do have that internal mechanism to have ready access to push our patients for higher level care. So that really is not a disadvantage in our particular region. It's always subject to rules and changes. That's the one thing I need to wrap up. I guess my message here is we've got a good thing going. Who knows with all the reform going right now and the discussions on the deficit. If I can just go real quick, we'll just push right through to this end on this slide. And we've got a very precarious situation with our budget deficit. And obviously Medicare and Medicaid entitlement programs are being looked at. So far, I think we're going to be maybe blessed with the rural model being such a small piece of the overall Medicare payments that we won't get looked at too closely. But if we do lose this cost-based reimbursement, all those good things that I just said, and number one, the good thing about it is that if reform comes out as Dr. Watson suggested, I know that may be repealed, but if we have more Medicaid population, more of our population converts to the Medicaid product or the exchange products, we are really poised to do very well and treat those patients. As I said, we can recruit more physicians pretty easily with our model, and we have the payment mechanism in there for additional Medicaid services. So that's the good news for rural medicine here in our hill country. And if you have anything you can do to help with Congressman trying to preserve our existing rural health model, please write your letters. Thank you very much.